All right, let me start over. Hi, everyone. Welcome. Thanks for joining the community practice this month. My name is Ryan Kronk. I'm with the Water Institute at UNC, and the theme of this month's webinar is on water quality. We're really excited. I think this is the first session we've had on water quality in the past couple years. So I just have a few quick announcements before we jump into our speaker this morning. I want you to save the date. We have two upcoming community practice webinars. In December, Dr. Rick Johnston and the JMP team at WHO and UNICEF will be presenting on the latest healthcare facilities report, which you may have seen. It was published, I think, a month or two ago. So he'll be presenting some findings from that. And then in January, the WHO will be presenting on their latest wash fit evaluation. So those are the next two webinars. We've got a lot more content in the works for 2025, so we should have a really great lineup going into the new year. I also, hopefully you saw from the email, we had our last month's event was a hybrid event from the UNC Water and Health Conference. We had a action-oriented research and practice agenda for Washington healthcare facilities. You can check out, I'll drop the link in the chat once we get into the presentation, but you can watch those on demand on the Water Institute's Water and Health Conference YouTube channel. There's also a lot of other great content. You can see the links to other healthcare facility presentations in the newsletter that we sent out a few weeks ago. So our agenda for today is we have one presenter. This is a really amazing presentation. I'm really excited from Dr. Leanne Ong, who I'll introduce in just a second. She'll be presenting on some work that she's been doing in Bangladesh on water quality. And then we'll have a plenary discussion. We have the privilege of having our colleague Maya Vandeman who's the Chief of Health at UNICEF Bangladesh. And so I'll sort of moderate a plenary discussion with the two of them. So with that, let me briefly introduce Leanne. So Dr. Leanne Ong is a third-year PhD student in the School of Geography and the Environment at the University of Oxford. This is why she is so amazing for this community. She was a critical care physician for 16 years after she graduated from Imperial College Medical School and did her specialist training in London. Her clinical career spanned critical care medicine in the UK and Australia, including rural healthcare services in Australia. She cared for remote indigenous communities and supported cardiac missions in India and the Pacific. She then transitioned to global health after she did her master's degree at Oxford, and then she started collaborating with UNICEF Bangladesh on the Washington healthcare facilities agenda, looking at the intersection of WASH services and quality of care. So the empirical evidence from the collaborative action research has been really instrumental in triggering policy action with development and other government partners in Bangladesh. And she's currently working with UNICEF Bangladesh to revitalize the National Washington Healthcare Facility Strategy and Action Plan with support from the UK government. So with that, I will stop sharing screen, and Leanne, you can take it away.
Thank you, Ryan. Okay, apologies. All right, I hope you can see my screen here. Thank you very much for giving us this opportunity to share this action research, which I must really highlight. This is a real testament of a transdisciplinary partnership that's come about from academia, development partners, and UNICEF, and we're working really closely with the Bangladesh government. And what we set out to do was to try and generate contextualized evidence for Bangladesh that really challenges our assumptions on what we understand about healthcare, Washington healthcare services, from the global framework to what is actually happening on the ground. And so I'm hoping to sort of really, over the next sort of 30 minutes, unfold and sort of share how we've come about this. And at the end of the talk, I hope that I build a compelling case to the title for this talk, which is Water for Healthcare Services is for More Than Drinking. And do we actually do have to rethink what our current approaches are of monitoring water services for healthcare facilities. So let me So the talk is going to be presented over in this sort of outline, where I'll just briefly sort of talk about the rationale and the country context that underpin this research before I take you on what I like to commonly do with when we do our stakeholder discussions and engagement is a virtual journey through the study sites so that you can really unpack the findings and sort of contextualize and make sense of the evidence that we've developed to sort of inform discussion. So I think, when the Washington Healthcare Facility strategy first came into sort of global awareness in 2016, we hear this being bantered a lot, that it is vital for quality of healthcare services, it's for ensuring dignity and human rights of all care seekers and staff. And we see this mentioned a lot in all the global health strategies. It cross-cuts all the different frameworks from quality of healthcare, universal health coverage, IPC, and those things are all fundamentally we talked about, and it's sort of you see WASH being mentioned, but it's for me as a clinician, what matters on a day-to-day is that WASH services is the bread and butter to what we need for infection prevention and control, which really is what you need to underpin the quality of care and patient safety. What we do know is that inadequate WASH services and hygiene practices do lead to higher rates of healthcare associated infections, or you might hear me occasionally slip into using the word nosocomial infection, which in turn actually exacerbates antimicrobial resistance burden. Because if you pick up an infection, it's inevitable. You do
Mhm.
need to use antibiotics to treat
What's up?
the
I'll be wait
infection.
for the other this thing.
And so what we
The pen
also
is
see
good.
is that what is currently more and more emerging literature on environmental health is also showing that hospital environment are also a reservoir for nosocomial or healthcare pathogens, which are already harboring this resistance. So as a package itself, holistically, WASH is crucial to disrupt this transmission of pathogens, which then causes harm. So we know that currently the rates of nosocomial infection is disproportionately greater in LMICs, low to middle income countries. And in fact, neonatal infections in babies that are born in LMICs are far greater than their high income counterparts. So I'm just going to if you bear with me here, I need to sort of spend a bit of time to unpack this slide because in the last 5 years in our discussion and working in this sector, I've realized that one of the things is about trying to generate that awareness that we are very familiar with what water is for cleaning and for IPC practices and for decontamination of equipment. And we just so assume that then the water is all there, the supply of water is all you need. But there's really not a great awareness that actually healthcare water systems can in fact become a paradoxical source of nosocomial infection. We are very familiar with the idea that water-borne pathogens causes diarrheal diseases, but we are less familiar with the idea that water itself in hospitals can actually be harboring pathogens, which are then spread to patients through multiple transmission pathway. Be it through the contact of direct contact onto the patient's wound, through colonization of the instruments that you're washing the water in and you didn't use enough antiseptic agents, or in fact also droplets. So then therefore, because of this multiple pathways of transmission, you can then cause a myriad of presentations from wound infection to bloodstream infection to urine as well, tract infection as well as pneumonia. So in fact, we actually do have plenty of empirical evidence showing this. And these data predominantly come from high income countries because this is where clinical surveillance is robust. And so, in fact, up to 1 in 5 cases of nosocomial infections referred to the American CDC can be attributed to contaminated water systems and water-based devices. So the risk is not universally across all patients that come into hospitals or healthcare facilities. We do know in these data that there's a disproportionate risk that is greater in patients who are vulnerable due to sort of individual risk factors. They are either having an underlying a condition or prematurity or extremes of age causing poor immunity, or in the case that in certain clinical areas like what I'll call high risk areas such as intensive care, operating theaters, we are actually doing very invasive procedures, meaning we are introducing instruments or invasive devices into patients. So we're actually breaching those natural protective barrier. The other area that's appreciated that we do know from our data is also patients with burns, because you lose your natural protective barrier. So those patients then are very susceptible to these waterborne pathogens causing nosocomial infections. And in this case, we call it opportunistic infections because they're targeting people who are most vulnerable, or we have created the opportunity for the bacteria to be introduced into the individual. So speaking from personal experience, this is exactly what I saw when I was working in the UK. That we had in an ICU, had an outbreak of what, in this case, of one of the pathogens that I've listed in the screen called Acinetobacter. These are normally pathogens that sit in that reside in the environment. They are not what we call pathogenic, means they are not very, very invasive. But if you create the opportunity and the conditions, they then get into the patients. And in our case, it caused pneumonia in quite a few of our patients. And because we had the clinical services to pick up on that, so the clinical surveillance, we could put it down to that one of our plumbing system in our intensive care was colonized with it. And what we were doing was introducing the bacteria through our bronchoscope when we are putting the camera down into the patient to look into their lungs. So those things are something that if you have a robust surveillance, clinical surveillance in a microbiology and a very astute microbiologist, we could identify the source and then introduce the relevant sort of the intervention to decontaminate and control the source of infection. Unfortunately, that luxury of having a strong surveillance capacity to pick up and trigger an environmental testing and address water system contamination is not there in high and low resource setting. So currently the recommendations when we look into the WHO as well as the CDC for environmental and water systems investigation, they said work closely with your local infectious disease team and only initiate an investigation when clinically indicated. So I think this is one of the sort of assumptions that we really do need to challenge. So how does this all fit into the context of the current global and national water services sort of standards? So the JMP WASH service ladder currently defines basic service as access to improved water source on the healthcare facility premise. So the tacit assumption is that improved water source, therefore, have the potential to deliver safe water by the nature of the infrastructure design and construction. So these include examples like pipe water, boreholes, tube wells. The list is there in the JMP sort of handbook. So I won't go into a great detail on that, but what is not explicitly included in the basic service definition is that they do talk about functionality and premises, but quality at the moment is something that comes up in the advanced indicator, where although they do not mention it in the basic, they actually do advocate for, but in this case, drinking water monitoring for safety verification by the absence of fecal indicator bacteria. So that be it E. coli or others, and or in the case of Bangladesh, their fecal indicator bacteria that using is thermotolerant coliform, and also for any other chemical contaminants. So one of the one of the things that I just want to highlight here is then, the current approach that we are monitoring in the monitoring of JMP, so water services with the current framework, is that we are actually emphasizing on infrastructure access. And drinking water is really much more in the forefront of our thinking. And the other pathogens currently are not so as explicit, and that the water for use is currently not as evident. So I'm just going to put into context where we are before I dive into how this research was conceptualized. I'll just briefly set the scene on where Bangladesh is and they sort of give you a brief overview of the Bangladesh healthcare landscape. So currently, since its independence in 1971, the health services in its current state is really much a conciliation of historical and development agenda over the last 5 decades. So it's a really complex health service landscape where you have a government sector, private sector, and a really vibrant private sector with non-NGOs working in all at the same time, engaged in health service delivery. The private sector is booming to the point that it actually has double the public infrastructure and human resource capacity. There's better water service coverage in the private and NGO facilities. And unfortunately, currently this is sort of reflected in sort of our surveys that we have seen in the National Hygiene Survey in 2018, that you have healthcare facilities in the government health facilities are actually lagging behind when it comes to hygiene standards. And currently, there are 254 hospitals, government hospitals, that are serving over 179 million of population, of which 2/3 of the Bangladesh populations are living in a rural area where there is the highest rate of poverty. The healthcare needs of the rural poor are primarily served by the public and NGO sector, while the government hospitals are crucial for providing emergency and specialist care. There's currently, with the limited resource capacity, the government hospitals are chronically overcrowded. So we are always looking at least 100 to 150% over the bed capacity. But really adding to the facility footfall is that the hospitals also have carers and attendants. That is with them and when they're admitted to the facility. So for every patient admitted, you need to factor in at least one additional person who's going to be using the wash services. So where are we now with regards to the water service coverage for Bangladesh? So this data, that was the nationally representative survey in 2018, shows that there's currently nationally, if you aggregate the both government, non-government, and NGOs together, there's reported as 80% attainment of basic water services. But when you look at the government healthcare facility, that actually is less. But what we don't have is that what we do not have is water quality data or health nosocomial infection surveillance data. So we really don't actually have an idea, these improved facilities, what is the quality of the water? We have no verification. So this is photos are ones that I've taken when I first started going out to the field. And this is the scene that I saw going out there. And you see the carers are the ones who are using the water. They are either going to be collected from the standpipe or from and there are very different sources whereby the patients will be collecting water at different points in the hospital. And they're using these water to clean the wounds. So my question was, how safe is the water? And so with this sort of current data gap, we set out doing a cross-sectional study to try and generate sort of an understanding of currently what is the water quality for Bangladesh healthcare services. So we set out with 3 objectives. One is that we wanted to examine the water quality services as assessed by the JMP, Wash and Healthcare Facility Indicator. And then we also wanted to see, having I've outlined earlier, what are the risk of water borne opportunistic pathogens that can be seen in the empirical literature. What are they there in the hospital waters for Bangladesh? Because currently there's really no reported evidence out there, data out there. And so the second part to the research was we wanted to ask was how useful is E. coli as a fecal indicator bacteria currently for drinking water? How useful it is to represent safe water for healthcare services? And lastly, as we also then wanted to look at is that what are the environmental infrastructure and behavior risks, then therefore that we see in the current health system setup that it does impact on water quality. So this study is, as you can see on the map, was done throughout the country, and they were all hospitals that were chosen from all as Bangladesh. So UNICEF Bangladesh really does have a wide country coverage. We sort of went to all these programmatic areas whereby looking at specifically government hospitals that are for the vulnerabilities that I've highlighted earlier. The patients who are being cared for are the rural poor. And also we wanted hospitals whereby we focus on hospitals in this case because we know that the risk of waterborne infection is greater in hospitalized patients. So we looked at hospitals offering inpatient care, routine and emergency maternal and newborn care, as well as surgery. So this study was done over 2 phases. As the first time we were using a sort of seed fund as well as contribution from UNICEF to sort of really do a pilot exploration. What is just scoping out there, a cross-sectional survey in the pilot to try and understand what is the state of the water? If we just tested for E. coli and did a screening panel. And based on the pilot study, we then went on to do a seasonal, sort of more in-depth study in the second phase. So to generate the evidence, we did a mixed method approach. The idea is to try and capture doing a multi-dimensional assessment. So not only we were just systematically inspecting the water system from the source to the tap, at the same time we sampled and tested the water as we were inspecting it. And then we also lastly did a structured interview with the hospital stakeholders. So wanting to really understand currently how the water system is set up, what sort of O&M practices they're doing to the water systems, and as well as the wider wash services. So this holistic data capture then allows us to make sense of the water quality results. Because sometimes we often see it's just a water quality results being churned out and really try to put that into context. Where was it collected? What was the infrastructure and environment around it? And was it recently serviced that sort of influenced the data? So just briefly, talking through what our sanitary inspections entailed was that I took a reference from the WHO sort of small water safety plan framework. And there were very useful sort of WHO sanitary inspection tool already out there, allowing us to sort of look at the small water systems. But what I did was I customized it to sort of incorporate so the additional risks that you get that's associated with building water systems. And that I sort of took references from the WHO water safety for buildings. So that meant we had to really build into consideration that you have the source, it goes into an underground reservoir in the case of Bangladesh, and then going up to the overhead tank. So currently in our current water safety plan for small water systems, we tend to just focus at the source side. So therefore, this just required some customization for it to work for the hospital health water network. So during that sort of systematic walkthrough, we then identified any of the hazards and risks that can then undermine the water quality. So as I mentioned, water then was simultaneously collected systematically through the network from source to tap. In the pilot, we actually did also a small group of what we call non-clinical areas, but the bulk of our work is focused in the clinical areas. So when I talk about clinical areas, we're looking at taps that the water, we are focusing on the taps that are used for hygiene practices in high-risk areas. In this case, would be maternity unit, operating theater, where people were using it to scrub and sterilize their hands before doing interventions, or using it to clean the instruments. In the low-risk areas would be like outpatient clinic or the inpatient ward, where there are lesser invasive procedures happening. So this is just to give you a taste of what we did. So the water samples were then collected and maintained by cold chain and processed within 24 hours in Dhaka. So I'm not going to go into too much detail about how we came to select the bacteria, but these are the panel of pathogens we select that were then funneled down for our testing. So critically, I'm going to focus on the 6 that's in bold. We looked at E. coli because that is currently my comparator or my standard bearer. And I also then looked at all the other environmental pathogens which are currently implicated in the available literature, or priority pathogens, I call them, for nosocomial infections. You'll see also that there's Legionella. So Legionella, in people who are very familiar with Legionnaire's disease, this is actually a notifiable disease that whereby in certain countries and jurisdictions is actually a public health mandate or requirement to actually do surveillance or water systems, including cooling towers for the bacterium called Legionella pneumophila. And it also has other types in the family that can cause Legionnaire's disease. So we also looked at Pseudomonas, Klebsiella, and Staph aureus. So I'm now going to come to the the results. So I'm going to take you what I call the virtual walkthrough of the water systems, and this is exactly what I see, and our team sees when we go through systematically. So this is an example of the types of water source that we see there. As all the hospitals, we wanted to test this idea that if they are infrastructurally safe, or meet from an improved source, what is the water quality? So all hospitals have improved sources, and in the case of Bangladesh, they are on-site tube wells. 1 or 2 hospitals also actually had pipe system coming in, but they only supplied as a very small subset of area. But as a whole, I would say 98% of our water services are from on-site tube wells. But what this picture is trying to highlight is that you see that there's a lot of exposure to environmental contaminants. And so these are things like medical waste, grazing animals, and include the one on the left, you can see it actually has it next to the hospital drain that's draining the wastewater. The other thing that we see a lot is that there's a lot of opportunities as we walk through the hospital, that the storage systems are not necessarily all protected. So there's a lot of defects in the infrastructure, and therefore you're exposing the water systems to environmental contaminants. So the picture on the right-hand side, you can see there's a crack on the inspection cover, and then you actually then see that there are grazing animals. So this is the underground storage tank. A lot of the overhead tanks that are there have their lids actually open, either due to the fact that there's a gust of wind, they're not secured. So the other thing that we see as well is that currently none of the hospitals have a water safety plan or any evidence of routine maintenance for a myriad of reasons, lack of capacity, lack of awareness. And one thing we do see is that there's actually little knowledge of the water system setup. So you have taps where there are aerators, which are caked with biofilm. And then the picture on the right-hand side is then to try and show you these are strings and strings of biofilm that we could see as we're collecting the water after we remove the aerator. And the picture at the bottom is an evidence of a storage tank overhead storage tank that hasn't shown objectively any evidence of maintenance, because you can see that ingress of vegetation into the tank itself. So
Lee, I just
yeah,
want to give you 10 minutes.
10 minutes, thank you. And so lastly with the sort of on part of the inspection, just to give you an idea before I now share the final results on the microbiology results, is that we see that the drinking water setup is really diverse. But on paper, they all meet improved technology. So because they have come from an improved source, either piped through the storage tanks or a standpipe, a submersible pump into a tap that's dispensing off the wall, a hand pump to a very sophisticated reverse osmosis sort of water treatment system. So what we then, as the team did, was that whilst we were doing the sanitary inspection, they at the same time then collected the water. So then I can triangulate the water results to what I then see. So now taking you all through the results. So having given you a taster or what you visually have, what we visually see before we even test the water, then you're going to see that, not surprisingly, that the water quality, there's a huge disparity when it comes from the groundwater right down to the storage tank and before it gets to the tap. Yeah, there's a differences between the drinking water and the tap. Only as on 33% of the water that are dispensed at the tap are free of any E. coli. So this is using the water quality as represented, I apologize, by the WHO drinking water indicator. So why this sort of big drop in itself is that you see that the source itself, even though that on the surface itself may show some surface contamination, but a lot of the water are going into, all the sources are into deep tube wells. So they still are actually protected until they get into the storage systems. And that's where all the opportunities of contamination pathways occur. And you see this big precipitous drop in the water quality from 80 to 44%. So what I'm trying to show in this slide is that if you actually just look at drinking water alone, you'll be then, and measuring just drinking water, you'll be lulled into this false sense of security that water quality is actually pretty, reasonably good at 80% free of E. coli. But in actual fact, only 33%, as I've mentioned, in the water that's used in the tap are free of any pathogens. So the drinking water quality also varied by technology. So even though we don't have currently there are only it doesn't show any statistical significance because it's a small number of samples, and also that the water quality overall is pretty good. But there's a signal overall that the water that comes from certain technologies are actually more likely to be showing contamination. And these tend to be water that are supplied through the hospital water network, whilst water that are supplied from their own water source and not connected to the systems that maintain their water quality, and it reflected their hospital main water system. So water systems with poor sanitary and infrastructure conditions also had worse quality. So how do how put it into context on the flow diagram to sort of visualize the change? You can really see this sort of very precipitous drop, as I've mentioned, from source going down to the storage tank. So, and by the time, unsurprising, then water from the taps that are downstream to the storage tanks that are very contaminated will also be contaminated. So as a result, only 45% water that started out as E. coli free at the source remain E. coli free or low risk at the time it gets dispensed off the tap. So just going through the last 4 slides now, just to try and then tie it all together. The other elements to the question was we wanted to see whether there were other nosocomial pathogens involved, co-detected in the water. Now, concerningly is that currently we do not have any local epidemiology to guide our data, as I've mentioned. But what we see in the regional studies is that currently there are that bacteria that we are co-identified in our waters in our study, they're theming of all these Acinetobacter pseudomonas, the high recovery rates of those. And these are the same bacteria that we see in regional studies, like in the case of this one I'm highlighting on the right side in India, whereby they were looked, this is a prospective study looking at newborn sepsis in babies that are born in hospitals in Delhi. And in these studies, which are really a stark contrast to high-income countries where where newborn sepsis or early neonatal sepsis are usually from a bacteria that are carried within the maternal tract, so both by mums. These bacteria that are seen in the Delhi study were predominantly from what the same bacteria that we see in our water, Acinetobacter, Klebsiella. These are typical sort of nosocomial pathogens or hospital pathogens. So, and they also harbor a very high rate of antimicrobial resistance. So coming back just as a reminder, these are the bacteria that are seen in our high-risk areas. So these are the patients that are then the most susceptible to these opportunistic infections. So putting it all together, so if we are looking at the current JMP Washington Healthcare Facility Reporting Metric, all our hospitals currently meet the required standards for water services by infrastructure access. But when we assess the water services further by water quality for the absence or presence of E. coli, Pseudomonas, and Legionella species. And the reason why I picked those two is that they currently are the two pathogens that have established water surveillance guidelines globally. So in the case for the UK, we have a recommendation for the cutoffs for Pseudomonas, and there are multiple countries that have cutoffs for Legionella. So you'll see that only if we do this sort of stepwise assessment, only 12 or 19% of the water collected from the high-risk areas actually meet safety limits for use. So taking then the question is, so how useful is E. coli as a predictor of safe water for use? One of the challenges we find currently is that because the environmental pathogens are so prevalent across all these unmanaged water systems, that they actually have a high level of recovery. So in the case, you're up to 70%. So even in the absence of E. coli, you're still going to find these bacteria being there. And when you when you then analyze and translate that into what we call predictive value of a test, is that we're then looking at how useful is E. coli as a water safety predictor. In this case, putting in lay language is that, if I have a positive test, E. coli test, what's the likelihood that there's a presence of a studied pathogen? So because it is so prevalent, that you can find that when there's a positive E. coli test, you're inevitably going to be worried that there's going to be Acinetobacter and Pseudomonas. So that's why the positive predictive value is very high. But for me, the most concerning thing is that the negative predictive value is that in the absence of E. coli, what's the likelihood of that test to say that it's safe from other bacteria? Is actually doesn't perform very well. There's only 5% and 30%. So what that means is that there's only the likelihood that you have a false negative rate of 70%. So you're only correctly predicting the absence of those bacteria in the case of Acinetobacter in 30% of the time. So this will be my last two slides on the results. And then we'll wrap it up with a discussion that's a concluding slide. Currently, there's the bacteria that we have actually isolated. What we did was we determined what would the antimicrobial resistance. So that involved doing what we call an antimicrobial susceptibility testing, which meant getting the bacteria plating out against different antibiotic discs. And what we did was for every type of bacteria that we isolated, we used these sort of CLSI guidelines for every antibiotic class that is relevant, and then we mapped it out. But very concerningly is the rates of multi-drug resistance in these sort of bacteria. So the top one is E. coli, it's startlingly high. There's no sensitivity in any of the bacteria, but multi-drug resistance is defined as resistance to at least 3 classes of antibiotics is high. So that means if you get infected with one of these bacteria, the risk of treatment failure, prolonged hospitalization, additional costs, and even death is significant. And how do these rates compare to the Indian study? Are very comparable. And having sort of tying it all together, if we see that the source of contamination is coming from within the hospital ecosystem, which is already a really well recognized as a and what we call an antibiotic hotspot, if these pathogens in the environment are then seeding back into the water system, we shouldn't be surprised that then the bacteria that then comes out of the tap will carry the same sort of resistance pattern. So lastly is that currently what we also shown in our study is that there's these waterborne water quality a risk is not uniform throughout the year. So there's a seasonality to the bacterial growth. There's actually a microbial bloom in the E. coli and the opportunistic pathogens, in the hot season. So I'm only just showing the tap water at the bottom against the drinking water at the top, because the tap water is a reflection of storage. So you'll see that. So in the storage systems that are unmanaged, when in the hot season, there's a real surge in the bacterial growth. And so there are some critical for us reflecting on how this sort of what implications it has for our policy, your timing of the and practice. It's as highlighted on the right-hand side, your timing of when you do the sampling, when you actually do the water system maintenance to try and reduce sort of the pathogen exposure to patients and staff. You were having to purge the system and clean. Would it be better to do it during the colder months when the bacterial burden is lower? And also, lastly, is that there is a whole discussion about the need to have good storage system as a climate mitigation and climate adaptation and ensuring there's water supply. But we need to make sure that then they are actually proactively managed. So lastly, this is the summary slide to sort of bring it together in the context of the time. That currently, what I would like to, my take-home message is that if there's an interdependency of the hospital ecosystem and water system design and management, and how this all then interlink and impact on water safety. But currently, if we are only looking at drinking water quality alone, we're really we're overlooking the other risks to patients, in particular the vulnerable patients from opportunistic pathogens, through other transmission pathway. And depending on the hospital setup and how the systems are devised, if you have, in the case like Bangladesh, where you have your standalone drinking water that's completely separate to the complex hospital network, your drinking water quality will not reflect the tap water quality. So access to improved infrastructure alone is not adequate as a measure of water services in a complex system. And so with the deteriorating water quality from source to final point of use highlights that the importance of considering water system management in our healthcare WASH strategy. Thank you. So just to couple of just a quick acknowledgement that this work is possible, only made possible through the sort of support of the people stated on this slide here, that we really have to acknowledge the role of the government of Bangladesh, in particular the Planning, Monitoring and Research Division of the DGHS, that really sort of facilitated our access to the hospitals. And it would have been possible through the brokering and constant sort of work and advocacy from UNICEF and our other partner who actually did the sort of water quality testing for us and developing all the lab analysis with me is the team in ICDDRB and my funder and supervisor from the REACH program. So thank you, Ryan.
Thanks, Leanne. Yeah. So I want to invite now for discussion also Maya Vandinant, who I mentioned at the beginning. She's the Chief of Health in UNICEF Bangladesh, supporting the Ministry of Health and Family Welfare and improving well-being of children and women in the country. The health program supports the government in strengthening the health system to improve IPC, quality of care, and reducing AMR. UNICEF Bangladesh is working on the Washington HCF strategy with the government. And so we're really excited to have her join us. She's got extensive experience working in other countries and has an MPH from London School. So thank you both for joining. In the interest of time, we kind of have a few discussion questions, and I'm wondering if you both could reflect on some of the short, medium, and long-term actions that could be taken from based on these findings. And in the longer term, I'm also seeing Rick Johnson's point in here about monitoring. What are some of the longer term policy changes that you could respond to water quality issues for healthcare facilities in Bangladesh, knowing that this is probably one of the most extensive water quality assessments in a hospital? What does this look like for, in Bangladesh, and then implications for other countries as well?
Yeah, thank you very much. Do you want me to start? I want to thank you very much for this opportunity to share this, and a big thanks to Leon for her fantastic work and all the support that we've received. So clearly, the Washington healthcare facility is an area that needs much more attention and much more resources. It's been a neglected area, I can say. Bangladesh has been developing their first strategy in 2018, 2019, and it was hardly implemented because no resources were directly allocated to it. So this study, actually, when Leon had the possibility to share this with the officials of the Ministry of Health, it got a lot of attraction. And with that, we have also had the opening to develop, or actually update and greatly improve the Washington healthcare facility strategy and action plan. So certainly this data is a wake-up call for all of us. And as a matter of fact, I just came back from a field visit, and the fact that we are now tuned in to the Washington healthcare facilities and the lack thereof, we can really sensitize the hospital managers to do improvements. And that is maybe the other direct impact that we have is there is this WASH Fit tool that WHO and UNICEF has been developing, which is based on a tool that uses, or based on the fact that if you assess and you have a local team from the facility reviewing the issues, and they can also make a lot of improvements. And that's kind of a PDSA cycle, and plan, do, check, or study, act cycle that you can improve each time. And this has been enormously helpful as a first step in improving some of the Russian healthcare facilities. And in the long run, we need to work on the strategy and action plan, have proper budget, and train health workers and the officials in and out, and also making sure there is an O&M budget for this. In terms of the surveillance data, I think we need to really look into how often we need this, and how relevant it is to maybe every 5 years have a sort of study to look into this, and whether the improvements are made in the absence of routine data, which would really be too high of an aim at the moment in Bangladesh. Thank you. Let me stop there and hear if there's any other question or context that I can add to. Thank you so much.
Leanne, any additional context?
Yeah, so building on what Maya is saying, is that sort of short-term wise, directly from our own work, is that we have really, as was mentioned, there's a lack of awareness of currently what water system setup is. So one of the short-term things we've been doing and working with hospitals is to sensitize them to the idea that it's more than drinking. And water system alone, currently just looking at the source, and then people forget what happens between the source and the tap. So the short-term actions we've been doing was getting the hospital, this is taking the water safety plan approach, getting them sensitized, getting them to understand your water system, getting them to do a walkthrough, a mapping, understanding the sort of setup, the current O&M, and then also during the sanitary inspection, getting them to identify the infrastructure and the environmental hazards. And that has allowed them to actually immediately address. So some of the examples I've shown in the picture, that sort of crack inspection lid, the next time we came, they actually repaired it. And we actually do see a change in the water quality itself, whether it's because of seasonal side, removing and containing any environmental hazards. So those are the short-term goals we're doing. Middle-term goals that we are trying to work on is now trying to see how we can embed this sort of PDSA cycle into sort of a more regularity to it, because that is the element that we have to work very closely with the other implementing partners who are part of the engineering arm of the government services. So that's the sort of short-term element I can sort of contribute for now. Thanks. Over to you.
Great, thanks. I'm wondering if you could reflect on how might different healthcare facility types respond differently to these findings? And for example, how might some of the rural clinics in Bangladesh respond to these findings from hospitals?
So first thing is that it's what I hope I can try to come across in the work is that there's a differential risk of water quality to patients, depending on the sort of factors I've mentioned, the types of services that you're delivering, the interventions you're doing to them, and also the patient's sort of individual factors. So we look at the smaller hospitals, which is actually the bulk of our hospital systems, the outpatients, the dispensaries. They're still going to have water in the form of, and their contact of water is much more non-invasive, and they're also doing it for drinking water. So the universal principle of safe drinking water applies across facilities. The next element then, but if you then start to introduce things like storage systems, same principles we apply in household setting. Storage systems need to be maintained and kept safe. So it's all this idea of reducing secondary contamination. But then you sort of build it up, sort of scaffold on. So if you start to build and make your systems more complex, then, and you start to need to do interventions like childbirth, you then need to be much more proactively considering how your water system is going to be maintained and stored, because this is where the opportunities of secondary contamination come in. So coming back to rural facilities, simple water systems for simple use, principle of safe drinking water applies, and then you then scaffold the sort of management, risk assessment and management accordingly as your facilities scale up.
Great. Maya, I'm wondering if you could reflect a bit more about what you see as some of the challenges of addressing wash services and therefore water quality issues in healthcare facilities in Bangladesh. I'm wondering if you could specifically reflect on, what is this, what are going to be the sustainability challenges in terms of getting the government to commit to routine monitoring, commit to PDSA cycles, commit to making the investments necessary to upgrade healthcare facility water services. What are the other pieces of evidence that are needed to convince the government to make these types of investments, or what other resources are needed?
Yeah, thank you very much. Very pertinent question. First of all, the infrastructure is still insufficient. Higher level of hospitals are heavily utilized. I just came back, what I said, from a field visit in one of the hospitals. 600% was overcrowding in terms of inpatient, and outpatients are also very, very overcrowded, and the facilities are simply not enough. So there is a need to work, what Leon was also just saying, between the health sector and the engineering departments. They need to be smarter in building their buildings. They need to think about where to put the water taps and etc. In terms of the patient flow, and they need to need to really take serious the cleaning of the hospitals. It's actually very basic. So we are actually in a pause in an intermittent time period where the operational plans are not working as we call them. So that's the development budget, and it means that some of the hospitals have challenges to get enough cleaners. So you can see how basic certain things are. So that is certainly something, and we believe that, and we've actually experienced, if we have this kind of evidence, and we can also bring in the cost effectiveness and the impact that WASH actually would have on reduction of AMR, reduction of hospital infections, we can also make the further case of investing in this. So the cost effectiveness data is really an important piece that we should consider. We are all having to cope with limited resources, as we know, and as this is a neglected area, it's really we need to bring forward why it's so important to invest in this. The other piece, I think, what we really need to realize is that leadership and the ownership of this work needs to lay in the health sector, and they need to be able to call upon the different other departments like engineering, DPHE, that is the water department, public health and engineering department, but also the hospital intendants need to be able to call upon their engineers, and that is still very, very challenging. The other piece, I think, what people really didn't realize until Leon presented this, is the hazard that the non-clean hospitals, equipment, services can bring to the most vulnerable in the hospitals, and that's really an underestimated issue. And last but not least, the climate vulnerability of the country is, of course, to be mentioned. We are every year we are going through flooding. We have had a huge part of Bangladesh with 6 million people flooded, which means the health facilities, especially the primary rural health facilities, but also the first level referral centers are flooded. And these kind of issues are also to be taken into account. So if we have like ground boreholes, and then that goes into groundwater tanks, these are per definition problematic. So these kind of things we also need to think of in our infrastructure and our investments. Thank you.
That's great. Thank you so much. All right, we are at time. Thank you so much, Leanne and Maya, for your time and for your work in this space. This community really appreciates it. For everyone else, please join us at our next 2 webinars. Stay tuned for the emails with the signups for those. We've got great stuff coming from the JMP and from WHO and WashFit. So thank you all for joining. Have a great rest of your day. Thank you.